That's a great question. Cholesterol has been implicated in a lot of studies for macular degeneration. We know it has effects on the blood vessels that are underneath the retina and in this layer called the choroid, and that we lose those blood vessels more in people who have hypercholesterolemia. Bringing them down in macular degeneration helps. We would guess that it probably helps in C3G. I know that's a problem when people are getting proteinuria and things. They oftentimes will get hypercholesterolemia. So it is making a jump. A lot of times in medicine, when we think something makes sense, it doesn't make sense. So I hate to tell you that I know it's the case, but I think it would probably be best medical practice for the eyes as well as so many other things in the body to try to get the lipid profile to be stabilized. I would say, I mean, the easy answer is we don't know for sure. But what we do know from other aspects of when people do have drusen underneath the retina is that there are several courses that the overlying retina will take. One of them is that if there are people who, for whatever reason, their body gets rid of the drusen, and the drusen can go away, and the retina can remain remarkably intact in that area. There's other people that are building up these drusen where the tissues that are kind of constipated and spitting that lipofuscin, that material out into the drusen, um, finally give up the ghost and die. The drusen also go away. They resorb, but those are the ones that are left with those withered spots. And so there's a couple of courses that we know that drusen can take, and it depends a little bit on how the health of the overlying cells are. But if those cells are still have enough life to them, uh, control of the thing that's causing the material to come out can improve the process. And so, what I would say is I have high hopes that these medicines may be able to take people like your daughter, if you know, again, and get at least some of those drusen to go away and never end up with any withered spots, or maybe less withered spots. So sometimes, you know, we have to take our successes where we can for things, and you can't be your own internal control and you know, take a medicine and not take a medicine. But sometimes we have things where we have a lot less damage than what you would otherwise have, which can be a success still. So, and I know certainly in the kidney, that's what we would be looking at as well. I thought I'd be the third wheel on this thing. Well, actually, the drusen look a lot the same. So if you looked at them under a microscope, it isn't the same disease. But we know even in macular degeneration, when you look at them, there's a lot of complement proteins that are built up in these that normally, I mean, at a much higher level than what complement would normally be in that area of the eye. And something is going on to do that, to activate the complement system a little more in those areas, we think, at least. And we do know that people who have things like complement factor H variants for things, something that slows down the normal breakdown of complement. If you have these mutations, even if you don't have C3G, you can get more complement, you know, in these drusen. And so there are things where they're similar. Now, there's probably a lot of things that if we could hone down into them are different. And again, it's a partly a wonderful thing to these people, but you know, we have a lot of people with macular degeneration, age-related macular degeneration, who die. I mean, they're elderly people, they die. We get histopathology from them. We can see their eyes for things. People will give up their kidneys, maybe when they have kidney damage for things, so you can see things. We don't have a lot of people who are willing to give up their eyes, and so we don't really get a lot of the maybe the tissues to be able to do certain things that we would love to be able to do and answer some of these questions. super hard, I think, to tell if you see somebody at an older age and they've never had a prior exam. I mean, the easiest way usually is just, I mean, a lot of people get the disease when they're young, C3G, and they develop their findings well before the age of what somebody develops macular degeneration. But there are exceptions, and I, there's people who develop things later, as I understand. These are the experts who should answer those questions. Yes. But that I think makes it very difficult. But in a certain way, it may beg the question. It may be that what you do is exactly the same, and so it may not make a difference, and it may be treating it. If we're good enough and we could just treat things in the eye, we might end up, if you had some local complement control, it could be that we would do that with people with just advanced macular degeneration, early advanced macular degeneration, that everyone might get a complement inhibitor in the future. I'm not saying we know that, but it might be that it would be the same for macular degeneration or C3G.
Short answer is no. Yeah, the short answer is that information was collected if it was available. But to my knowledge, it's not been made available publicly in terms of how many of the patients actually had genetic driver. I know this because Nikki, I mean, all the people on my team had to collect that information before we submitted it. But at some point, we may get the information. But right now, if you're going for the question of, do we know, do all nephritic factor patients respond and the genetics didn't? We don't know that answer. I don't know if you want that. So in the Fabhalta trial, I think I just counted this morning. I think there were 74 patients. And when you say response, I think it depends on whether you're talking about glomerular disease response versus urine protein response. But the numbers were there were very few patients in the trial that had zero response. Can I say it that way? Because again, we don't have the individual data. They did the cumulative data, so they knew that you had, for instance, the 35% decrease in urine protein or eventually the 40% decrease in urine protein, that sort of thing. We don't know how many non-responders. And we don't know if the non-responders are related to what their driver of disease was. Well, I mean, we're starting to get that understanding in moral, because we're looking at it to that degree of detail, but even we don't have it yet, and we've begun to look.
We have some of that information because we do a lot of the testing in our lab, but anecdotally, well, when iptacopan was developed, it was selected as one of 3 meds that Novartis was testing, and they tested those meds using patients from our C3G biobank. And the med that was carried forward was iptacopan, and it didn't respond as we would predict in one patient in our biobank who had factor B autoantibodies. And that was reported in their PNAS paper describing iptacopan. So we know that even before it was made available, it won't respond, it won't work in everybody. But one of the areas that the MORL is actively working on right now is figuring out who it doesn't work on, and more importantly, why it doesn't work on the people it doesn't work on.
Well, and I'll comment just very quickly, at least from a renal standpoint, we know that controlling the blood sugar, controlling the blood pressure, controlling the weight, et cetera, these are all good things for the kidney. So you're right, understanding where you started and whether you need to improve that or change that ends up being very important. But also, I'll let Richard comment next, because understanding the baseline biomarkers, for instance, before being treated was actually part of your presentation this morning.
One aspect, you asked about the diabetes and obesity and things like that, and Carla mentioned it in her talk. As kidney function decreases. So as you develop chronic kidney disease, your factor D level independently rises. Your factor H related 1 independently rises. BA independently rises. So those are complement biomarkers. And so now there's a thought, and there was a KDIGO meeting on this last year or the year before, that associated with chronic kidney disease, there is an association of increased complement lability, increased complement activity, so that as a baseline, the ticking faucet of the alternative pathway, maybe in everyone in this room, if you were in chronic kidney disease, your normal ticking, dripping faucet would be dripping 10 times faster. And so you're more apt to get a complement related consequence of that. And so how that contributes to a disease where it's a complement driven disease like C3G and a complement associated disease like chronic kidney disease then becomes really complicated.
Yeah, and probably all of us will have a different comment on that potentially. But me personally, I thought that if we aimed at the convertases, we were, we've joked about this. We've got 2 new anti-convertase drugs. I can go home. I can retire. I don't have to think about it anymore. But it turns out it's obviously not that simple. What we talked about is there's going to be non-responders. We've got to figure out why they don't respond. We've got to make sure that they respond to the other alternative. If they don't respond to that, then we've got to make a plan C, if you will. So there's lots and lots of pieces still left. And that's just the clinical aspect. There are going to be a lot of complement biomarker / science pieces that we need to figure out. There is, like we talked about last year, you can go to clinicaltrials.gov and you can see exactly what's coming. Really not a lot is coming. What's going to happen, because I'm half of a pediatrician, what's going to happen with these drugs is they're going to get down into the younger ages. As you know, we only can get to 12 in one and 18 in the other. I'm hoping, our team is ready for them to drop them to the age of 6 at least. So we'll be ready for that younger group. That's the most important thing for us as a clinical trial unit. The second thing for me is that the most important, I didn't mention there's a C3 siRNA drug that's coming. There are other things coming, but again, the C3 siRNA would go at the convertase too. So I'm not sure it's added benefit. I don't know. What for me, I would like to see is coming is these new drugs that are actually targeting the B cells and the plasma cells. Because for those of you that are nephritic factor positive, if I could get rid of your nephritic factors, you wouldn't need a complement inhibitor in theory, right? If we don't know that that's actually the case, but that would be the next direction I would like to see us go as far as from a clinical trials unit sort of standpoint. But there's lots and lots of stuff to be thinking about in the scientific realm.
So that was a good question because both of those drugs act by stopping the circle and the convertase and the activity. So it's the same mechanism of action, and there's lots of other mechanisms that could be targeted. And so one is to increase the regulators, normal regulators. So some people in this room I know have low levels of factor H, and that's what's driving their disease or when they have disease. And if we can boost the level of factor H, then that's going to be a great treatment. It's going to be a great treatment for a lot of people. And so we're actually working with a group in Germany on a drug that they've developed that works with a different mechanism of action. And so there is a lot of room for lots more drugs, and there's a lot of room for understanding how nephritic factors work. There's a lot of work to be done.
Thank you.